So we have a talk today on contemporary management of chronic heart failure. Today I'll briefly discuss this topic. First, let's have a look at the epidemiology of the chronic heart failure. As per clinical criteria, the prevalence of chronic heart failure is 1 to 2% all over the world. And males are more affected than females, and in 65 years above patient, the prevalence is 7%. And 50% of patients with left ventricular systolic dysfunction is asymptomatic. And heart failure with preserved ejection fraction varies from 15 to 50%. And the incidence rate is 0.2 to 0.3%. And it increases with age. Now, around 62 million adults worldwide are estimated to living with a heart failure, and this number is expected to rise because of the increasing aging population, increased prevalence of various risk factors like diabetes, hypertension, and improved post-MI survival because of better management of acute coronary syndrome and STEMIs. Now, let's have a look at the natural history of this chronic heart failure. First, we start with a normal heart on the left side. After initial myocardial injury occurs, it may be SCS, it may be STEMI, then a patient may remain asymptomatic throughout. And after a few months or the undefined period, the patient may develop acute decompensation of heart failure. Then patient himself may forget the acute event when he had suffered the event. And that event may be with pulmonary edema requiring emergency admission and ICU care. And usually patient survive that first decompensation of heart failure, and subsequently he remains stable on medical therapy. But after a few months or varied period, he again suffered a decompensation as shown in a deep, it is a deep here. So again he recovered with treatment. Then again he may suffer. Now each decompensation is associated with a residual damage to the heart. So there is a progressive development of the symptoms, or progressive pump failure occurs with each decompensation. So, and with this recurrent decompensation, patient may finally develop end-stage heart failure and death after a few years. Now coming to the classification of heart failure, in ESC heart failure guideline of 2016, the heart failure has been divided into 3 groups. There is heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and has a reduced ejection fraction. So heart failure reduced ejection fraction is defined by LVEF of less than 40% and with or without symptoms, and heart failure with mid-range ejection fraction is defined as EF of 40 to 49%. And heart failure of preserved ejection fraction is EF of around 50% with elevated level of natriuretic peptide and other clinical signs and symptoms. But subsequently, it has been reviewed, and this mid-range ejection fraction has been defined as mildly reduced ejection fraction. Heart failure with mildly emerging data, patient with heart failure ejection fraction in the mid-range between reduced and presumed, that is 41 to 50% may benefit from neurohormonal blanket like those with a lower ejection fraction. These are important differences based on patient sex, with women and with heart failure benefiting from neurohormonal blockade at higher ejection fraction than men. Recent data support defining heart failure with reduced ejection fraction as less than 40%, mildly reduced ejection fraction, and normal if ejection fraction is more than 55% for men and more than 60% for women. This is published in JAC, recently published. So prevalence, I have already covered this. So chronic heart failure is basically a devastating burden, because despite the introduction of the treatment, the mortality rate for patients with chronic heart failure is about 50% at 5 years post-diagnosis. Now recently, there is a position statement has been published in European Journal of Heart Failure regarding the patient profiling in heart failure for tailoring the medical therapy. This is basically a consensus document which is followed by the ESC guideline of 2021. As per this consensus panel, it has been noted that despite guideline recommendation and available evidence, implementation of the treatment in heart failure is poor, and majority of patients are not prescribed drugs at target doses that have been proven to positively impact morbidity and mortality. Among others, tolerability issues related to low BP, heart rate, impaired renal function, or hyperkalemia are responsible. CKD plays an important role as it affects up to 50% of patients with heart failure. Also, dynamic changes in the eGFR may occur during the course of heart failure, resulting in an inappropriate dose reduction or even discontinuation of the decongestive or neurohumoral modulating therapy in clinical practice. So as patients with heart failure are very rarely naive to pharmacological therapies, the challenge is to adequately prioritize or select the most appropriate up titration schedule according to the patient profile. The consensus document identified 9 patient profiles that may be relevant for treatment implementation in heart failure patients with a reduced ejection fraction. This profile take into account the heart rate, it may be less than 60 or more than 70, the presence of atrial fibrillation, symptomatic low BP, eGFR of less than 30 or more than 30 per square body surface area, or hyperkalemia. The pre-discharge patient frequently still congestive also addressed. Now, personalized approach according to the patient profile. Adjusting the guideline directed medical therapy to the patient profile may allow to achieve a better and more comprehensive therapy for each individual patient.
Sir, I am presenting your presentation, not at your end. You need to follow the Zoom and tell me next.
Oh.
Right now I'm on patient profiling in heart failure.
Okay, that is our next slide. The core of heart failure treatment should be started in all patients with heart failure. So that is the core is at the center. This is dark level shown that SGLT inhibitors, beta blocker, SC inhibitor or ARB or ARNI or MRA or diuretic must be given in all patients with heart failure. Apart from that, depending on the heart rate, other therapy need to be added or discontinued. Depending on the heart rate and BP, as well as presence or absence of atrial fibrillation, presence or absence of CKD, hyperkalemia, or presence or absence of congestion. Next slide, please. Now coming to the tailoring of medical, according to some patient characteristic, like BP, heart rate, as I already told, some drugs may be reduced or some they may be discontinued or added. The black drug that is at the center of this diagram, this drug has to be given to all patients, and red drugs that should be reduced or discontinued. Blue drug that should be added according to physical condition. Now this slide shows a common comorbidity seen in heart failure patient and impact on the use of guideline directed medical therapy. Like comorbidity like coronary artery disease, if the patient have a CAD and angina, then beta blockers and evaporating therapy may help in control symptoms of CAD as well as in heart failure symptoms. The next, diabetes. If patient is diabetic, then GDMT has to be started, has shown similar benefit in the diabetic patient. Suppose patient have a chronic obstructive lung disease or asthma, then it may be a relative contraindication to the beta blocker. Starting with low doses of cardioselective beta blocker may allow easy use. And beta blocker should be given in patient with COPD and heart failure. Then next, coming to the comorbidity is depression. GDMT must be started in patient with depression, but depression is associated with low adherence to the medication, so compliance reduces if depression is present. Suppose if the patient have a erectile dysfunction, then thiazide, spironolactone, and beta blockers may aggravate the erectile dysfunction. But in this regard, the nebivolol is quite helpful, and this may reduce the erectile dysfunction. So in this condition, nebivolol is preferred if the patient have a erectile dysfunction. Suppose patient have a iron deficiency.
Sorry to intervene, please. Your slides are not telling with your presentation. Can you share your slide from your end, one of that? You share your slide because your presentation is not telling with the whatever they are showing. So please share from your side.
Okay, okay, sorry for this.
That's okay, one of that. Please share yours.
Share screen is not coming here. Actually,
can somebody help him to share his screen?
So there will be a green button on Zoom.
Green button on Zoom, okay. Yeah. I got it. Yes. 1 second. I'm very
share screen to provide the
Yeah. I have pressed the share screen.
Then you have to select the presentation.
Yeah. Now it is coming?
Yes.
Yeah, good.
Yes, good.
Okay,
good to go. Please go.
This is the comorbidity slide with heart failure. Next, coming to the iron deficiency, anemia, and chronic kidney dysfunction. So SC inhibitor, ARB or ARNI, MRA may have some limitation in use in patient with CKD or anemia. So diuretics may need higher doses to be effective. If a patient have a cardiac cachexia, then SC inhibitor, ARB, ARNI should be uptitrated carefully because of the orthostatic hypotension frequently seen in patient with heart failure with cachexia. Now, this is trials. This is a very congested slide actually showing various trials starting from VHAP to the galactic heart failure. Just coming to the management of heart failure, reduce ejection fraction. So, to reduce mortality for all patients with heart failure, we need to give SC inhibitor or ARNI, then beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. To reduce heart failure hospitalization or mortality for selected patient, then in volume overloaded patient, diuretic need to be added. Apart from that, sinus rhythm with LVV, then more than 150 millisecond, then we need to consider for CRT or ICD, CRTP or CRTD or ICD. And there is another presentation for device therapy, so I'll not cover this. Going to the next slide. Now coming with the Emperor reduced heart trial, SGL2 inhibition with empagliflozin is effective in heart failure with reduced ejection fraction with or without diabetes. So primary endpoint was significantly reduced by 25%, and p-value is highly significant. And first secondary endpoint also reduced by 30%. Now next coming to the Vericiguat, this is a newer drug, and a Victoria trial has been recently published in NEGM with over 5,000 patients with reduced heart failure with NYHA class 2 to 4. With after worsening event, it has been added with recent heart failure decompensation. So it has been shown that Vericiguat reduces the recent heart failure, hospitalization, and cardiovascular death. And the annual number needed to reduce this CV death or fast hospitalization is 24. Now coming there to the next drug, that is omecamtiv mecarbil. This is recently, this trial, this is galactic heart failure trial, is presented in SCC 2021, and this trial has been conducted in over 8,000 patients, and it is basically a myosin activator. It has been shown that this drug increases the cardiac contractility, and by doing so, it reduces the composite risk of fast heart failure or cardiovascular death in patient with heart failure. The effect is especially seen in patient with ejection fraction of less than 28%. Next, coming to the, let's have a look at the guideline. Now, diuretics are recommended in patients with congestion and heart failure in mid-range ejection fraction in order to alleviate symptoms and signs. As far as 2016 guideline for patients with non-valvular AF eligible for anticoagulation based on set to VAS score, NOACs, radar and warfarin should be considered for anticoagulation as NOACs as per 2016 guideline. But according to recent 2021 guidelines, these NOACs are recommended in preference to vitamin K antagonists in patients with heart failure, except in those with moderate or severe mitral stenosis or mechanical prosthetic valves. So NOACs are recommended over VKs nowadays. So with this slide, I would like to thank you for patient hearing. Thank you for patient hearing. And this is the brief presentation of chronic heart failure. Thank you for giving me a chance to present this.